So I'd like to introduce our speaker, who again will be talking about geographic atrophy in dry age-related macular degeneration, the new treatment frontier. So Associate Professor Andrew Chang is a vitreoretinal surgeon and ophthalmologist. He holds an academic appointment of Clinical Associate Professor at the University of Sydney. He is a consultant ophthalmologist and the Head of Ophthalmology and the Head of the Retinal Unit at the Sydney Eye Hospital. He is the Medical Director of Sydney Retina Clinic. Associate Professor Chang is enthusiastically involved in basic science and clinical trials research, receiving grant funding in Australia and the USA. His research is extensively published in peer-reviewed scientific literature. He serves on editorial boards of scientific peer-reviewed journals. So thank you so much, Associate Professor Chang, for joining us today, and I can't wait to hear what you have to say.
Thank you very much, Delaney. I'd like to show my screen now. Okay. What I'd like to do over the next 20 to 30 minutes is to share with you geographic atrophy, which is a form that we see with macular degeneration. There are new treatments coming, and I wanted to share that with you as well. We'll go fundamentally to how the eye is set up. The eye is like a camera, the retina is like the camera film, and if you look at the bottom illustration, you can see that the light focuses on a small part of the retina, and that is called the macula. That is part of the eye that we use for fine vision. This is another image here showing you that there are layers in the retina. And at this stage, I'd like to share with you an analogy to help you understand how the eye is formed. If you imagine that the room you're sitting in now is like the inside of your eye, the retina is like the wallpaper in a room. The retinal pigment epithelium, which we'll talk about, is in the gibrock layer, and the outside part of the eye is the brickwork. So the part of the eye that we're talking about now today, the retinal pigment epithelium, is that layer within the wall of the eye. Macular degeneration can be divided into a number of different forms depending on how severe it is. We have firstly early macular degeneration, in which a patient would have very little symptoms that we might notice a change if we examine the patient. Then the next levels would be intermediate, where there are more changes that are observed, and a patient might notice some slight alteration in vision. And then we have advanced macular degeneration, which causes loss of sight, dry macular degeneration, which is what we're going to talk about today, the form being geographic atrophy, and the wet form of macular degeneration, which many of you may be aware of, that is treated with injections. Macular degeneration is a leading cause of blindness and severe vision loss, which is why we're focusing so much on this disease. It accounts for 50% of vision loss in Australia. 1.2 million Australians are affected by this condition. And geographic atrophy, which we are talking about today, affects about 80,000 Australians. There is a progression from early to late macular degeneration, and this is when there is loss of vision. And as many of you may know, loss of sight isn't just simply losing vision, it also results in other issues such as fractures and falls, loss of independence, admission to nursing homes, and it affects our mental health as well. There are two broad types of macular degeneration, the dry type and the wet type. The dry type is where tissues at the center of sight, that is the macula, start to wear thin and wear out. And the wet type is where blood vessels grow in the central vision area And as these blood vessels grow, they bleed and leak fluid. And it is the bleeding and the leakage of the fluid that damages the nerves. So in general, patients lose vision a lot more quickly when they develop bleeding in the eye, that is, they have wet macular degeneration, as opposed to dry macular degeneration, which is a lot slower. This shows you the normal retina, and you can see here there are different layers which we've talked about. Photoreceptors, RPE. Now the RPE is short for retinal pigment epithelium. It is a layer of cuboidal or cubes that underlies all of the retina. This fine layer of cuboidal cells are really important in nourishing the retina, and in geographic atrophy, it is these cells that start to wear out. So if you imagine the retinal pigment epithelium a little bit like a shag pile carpet, when we are born, that shag pile carpet is all even and plush. But as we wear the carpet out, more traffic, particularly in high traffic areas, the shag pile carpet starts to wear thin. And as it wears thin, we call this atrophy or shrinkage of the cells. So when the retinal pigment epithelium or the RPE starts to thin out, the photoreceptors which detect light also don't work well. Early stages of macular degeneration are associated with protein material which deposits just under the RPE layer. You can see this on the illustration in front of you. We call them drusen. If we look inside the eye with a photograph, they look like little white dots. And that's how your eye care professional diagnoses this form of macular degeneration by looking in the eye and doing some other tests. So this protein material accumulates underneath the retinal pigment epithelium, and over time, it begins to damage the pigment layer, so that RPE layer, that shag pile carpet area, starts to thin out. This is what we see with somebody who has drusen. There are white dots, sometimes small dots that join up to form bigger dots, and this is called drusen. A patient who has drusen of this nature may start to notice that their reading vision isn't quite as good, but still can usually see very well. But this can then progress to what we call geographic atrophy of the pigment epithelium. That is that monolayer, that shag pile carpet that you can see here on the bottom left. That shag pile carpet starts to wear thin, a little bald patch appears, and that is when patients start to lose vision. It's called geographic because it has often a geographic type of shape to it. It represents like a country that you might see. Some are small, some are a bit larger. And it's called atrophy because this means shrinkage of the pigment layer. So think of geographic atrophy like wearing out of the shag pile carpet. Macular degeneration has a number of risks that many of you may already know. We know that it increases as we get older, so age is a risk factor. Smoking is a definite and modifiable risk factor. That is, there can be an increased risk of up to 3.5 times if people smoke. Diet has an issue too, and you can see here alcohol, sweets, fast food. All these can actually increase your risk of getting macular degeneration. I put in here comorbidities, and we know now that patients who have hypertension, high cholesterol, and cardiovascular disease are also more at risk of developing macular degeneration. And there are genetic factors, that is, often a family history of macular degeneration may be a result of an increased risk, and we are now looking at and have identified a number of genes that might be linked to macular degeneration. So what does a patient who has macular degeneration notice? Well, all of these symptoms that you can see here start out very mild and become more severe. So the vision might be distorted or slightly blurred. The central vision becomes affected. Some people describe a grey or black spot in their central sight because that's the area where the bald patch occurs. They may have troubles reading or even recognising people's faces. Magnifiers are needed in order to enlarge the image so a patient can see. And it's worse in dim light or at night because the photoreceptors that detect light work very much for colour, for high acuity, and also it is more obvious at night when these are not working. There is a very significant impact that geographic atrophy can have. We've shown that it has impact on quality of life. When we ask patients, their main issue is mobility being reduced. Their second issue is difficulty with reading. That is, patients who have significant geographic atrophy lose their reading sight. We don't know for certain what the cause is for geographic atrophy, but scientists have identified several processes. We believe that impaired or overactivity of the immune system in the retina, which cause inflammation, may not be normal in patients who develop geographic atrophy. Inflammation is really important because inflammation fights enemies of our body. They keep our health good. If we don't have enough inflammation or immunity, we get sick. If we have too much immune response, we can have other problems around our bodies, such as autoimmune disorders like arthritis, but also we believe macular degeneration may be related to this. Another issue is that the waste products which accumulate under the retina, because the retina is so metabolically active, can't be taken away. And this is what we believe may be causing drusen, those collections of protein, those white dots that I showed you. But as they accumulate, they can damage the pigment layer. And we know now that both genetic and environmental factors seem to influence this process. When geographic atrophy first occurs, it's often not directly in the middle. It's often a little bit on the side. And so initially a patient may not notice too much. They might notice that when they're reading the letter a little bit to one side is less clear. But as geographic atrophy enlarges, it begins to move more towards the center, and that is when the fine vision is affected. How do we as eye doctors assess geographic atrophy? Many of you may know that when you see an optometrist or you see an ophthalmologist, we use a machine to look at the cross-section of the eye called an OCT machine. Well, in that machine, there is also a light that allows us to detect autofluorescence. That light emits a certain wavelength between 250 to 500 nanometers. And so when that light hits the back of the eye, there is protein within that layer of RPE cells which emits back to us. So it looks white. When you have a wearing out of that shag pile carpet, a bald patch, it appears black. And you can see in the images on your screen that there are black patches where the macula is, and this allows us to highlight or diagnose geographic atrophy. This technology can allow us to assess progression. So this patient, MA, has been followed over every year since 2015 to this year, and you can see that black patch seems to be getting larger each year. That black patch, or the bald patch in the shag pile carpet, is just getting a little bit larger each year, and we estimate it to be about 1.2 to 2.8 millimeters per year. This is a fairly typical case of progression of geographic atrophy. So the challenges will be to stop geographic atrophy occurring in the first place, but as I'll show you, our treatments are aimed at slowing the enlargement or the progression of geographic atrophy. Geographic atrophy can also occur in wet macular degeneration. So patients who are having injections for the bleeding form of macular degeneration are likely to also have an element of dry macular degeneration or geographic atrophy. Some of you who are having injections might feel that the vision is just getting a little bit worse also, and your treating doctors will be saying, you have a little bit of dry macular degeneration as well. We know that that occurs. We know that often the two come together, and even though we keep the wet macular degeneration under control, the dry gets worse. Now, let's go on to some new treatments. To begin with, there are no proven treatments for geographic atrophy at this stage. We have good treatments for wet, but not for dry. So the good news is that the scientific community is now very much focused on finding a solution to this unmet need. If we look at these broad new therapies which are now under investigation, there are different types. Broadly can be divided into cell therapy, that is using stem cells, or gene therapy, or complement inhibitors, which are used to treat or modulate the inflammatory pathway, which I talked a little bit about. So let's talk more about these new therapies. Firstly, cell therapies. This is a really innovative treatment which involves umbilical tissue-derived stem cells to be injected through a tiny catheter under the retina, under the wallpaper. So this goes directly underneath, and we're injecting stem cells. So in a way, it's a bit like transplanting or putting in shag pile in that bald patch of your carpet where you don't have any more. Sounds really great and really promising, and the first studies, that is phase 1 and phase 2, have been done. There has been some promise, but when we do surgery and we make a hole in the retina, we can have other complications, and this is what has been seen. But often when we develop very brand new treatments, we refine the way we actually carry these treatments out, so in the future they become safer. This is another treatment, another cell therapy, where we're injecting under the eye a gene product which actually increases what we call complement factor I. This complement factor reduces the inflammation in the eye. This trial is currently ongoing. It's recruiting in the UK, US, Europe, and also in Victoria. That is another trial site. Promising, but is still under investigation. Involves surgery. That is, one has to get inside the room, use a tiny needle, make a hole in the wallpaper, and inject, a material or the drug. Let's talk now about complement cascade inhibitors. In geographic atrophy, we believe that the immune system is affected, that the inflammation becomes awry. Something is happening, and inflammation feeds in along the pathway at multiple levels. So new drugs have been developed to affect the complement pathway, that is the inflammatory pathway, at different points. This is the first drug, APL2. It inhibits a protein called C3, C for complement, number 3 protein. It's given by an intravitreal injection, much the same way as drugs are given for wet macular degeneration. The results of this trial were encouraging, and that is, with monthly treatment, we can reduce the progression by up to 30%. So that means the area of thinning, the bald patch, doesn't progress as big and is reduced by 30%. So very encouraging results. The phase 2 is actually completed, and we are now in phase 3. This study was done in Australia. Quite a few trial centres around Australia recruited to this study. This is another drug. It's called Zimura, and this Zimura is targeted at the C5 protein, complement 5, and it's also given by injections inside into the eye, like we do for wet macular degeneration. This trial was also encouraging, and in the phase 2 trial, it found that the drug could reduce the progression by 27% over the 1 year compared to no treatment. So I showed you that patient who had an enlarging area of their bald patch in their carpet. Well, this could reduce it by 27%. And this study is now open. It's now recruiting for a phase 3 trial, and the investigating sites are around Australia. This is another drug by Annexon Biosciences, and it targets C1q protein. It's given by intravitreal injection as well. Phase 1 studies were encouraging, and now this study is recruiting for phase 2. Phase 1 is first in human, phase 2 is the next level, and phase 3 is a much larger study to investigate whether these drugs are effective, but also whether they are safe. This next drug is really innovative. It's by Ionis, and it inhibits complement factor B. Because complement factor B is made in the liver, not in the eye, it's given by subcutaneous injection. That is, as you can see on the picture, a drug is given just under the skin, and the aim is to reduce plasma and also the levels of factor B in the eye. It is in what we call phase 1 trial is already completed, and it was well tolerated, and it's recruiting for now phase 2. It's recruiting for phase 2 study right at this moment. So in summary, we can regard geographic atrophy as an advanced form of dry macular degeneration. Geographic atrophy usually progresses from early forms of AMD. Sometimes it can just appear on its own, and sometimes it can coexist with wet macular degeneration as well. We are now gaining insights as to the cause, and if we can identify that, we can find treatments to address the abnormality. New clinical trials for these new therapies are underway, and many are currently recruiting. Many of the studies, if not almost all of the studies that I've talked about today, have recruited or will be recruiting in Australia. There are different criteria for patients who get recruited into a study. Often it depends on the level of vision that a patient might have, or the size of the bald patch in their carpet, or where the bald patch is in the carpet. And so an investigating site would look at each patient, screen them, and see whether or not a patient might be suitable for these new therapies. Thank you very much, and I appreciate greatly the opportunity to address you and for the generosity of the Macular Diseases Foundation in inviting me today.
Thank you so much for that, Associate Professor Andrew Chang. That was extremely informative, and I think everyone, myself included, definitely learnt a lot. Just a reminder for everybody, if you do have a question for Associate Professor Andrew Chang, you can pop your questions in. Again, just clicking on that question mark icon inside the speech bubble, and then you can type your question in the white rectangle at the bottom before selecting send. Before we move on to questions, however, I did want to talk quickly about the Macular Disease Foundation Australia and the work that we do. So our goal is to try and reduce the incidence and impact of macular disease, and we try to do this through our 4 pillars. The first pillar being prevention and early detection. So we provide accurate, current and ongoing information about macular diseases to the community, and that's nationwide. Last year, we reached almost 7,000 people through our education sessions. Our second pillar is support and services. We provide support for the macular community, and we also facilitate access to other support services. I'll talk a little bit more about this in a moment. Our third pillar is voice of the macular disease community. So it's our privilege to advocate on behalf of the macular community to state and federal government, designing policies and making sure things such as Medicare benefits are not cut. And finally, research and data. So 100% of funds donated to research go directly into our research grants program. Since 2011, we've actually donated over $4.1 million to 21 different Australian research projects. Now, if you would like some support or you have some questions, you can contact us on our toll-free helpline. That is 1-800-111-709. So not just for questions about geographic atrophy and AMD in general, but if you have questions about other conditions such as diabetic eye disease, or perhaps you have questions about Medicare or My Aged Care, or maybe even Centrelink. Or perhaps you know someone that has questions, but English isn't their first language, we can provide translated services as well. If you prefer to email, you can do that too. And our email address is education@mdfoundation.com.au. If not, you can also go on our website, which is www.mdfoundation.com.au, and you can find a whole host of resources there. And absolutely everything we provide is for free. So for example, if you would like to order some of our resources, such as an answer grid, you can order say 50 or 100 of them, and we'll post it out, no postage fee and no cost for the grids. And that's the same with the rest of our resources as well. Now, at the conclusion of this webinar, we will be sending an email to you, and that should be in your inbox in about an hour or so. And the email will have a couple of links. So the first link will be to a feedback survey. If you could fill that out, that would be really great because it just gives us some feedback on how we can improve future webinars. There will also be a link for previous recordings. So any webinars that you may have missed in the past, you can click on that link and choose which one you'd like to watch. And we're also going to send yet another link in the email. That's just going to show you what future webinars are coming up. And speaking of future webinars, our next one is actually going to be all about age-related macular degeneration. It will be on Wednesday, the 12th of May from 2 to 3 p.m. Sydney time, and it's going to be presented by MDFA's very own Drew Sherwin. If you would like to register for that, again, you can click on the link that you'll receive in your email. If not, you should be able to see a QR code on your screen, so you can just scan that with your smart device, and that will allow you to register. So it does look like we have quite a few questions coming through, so I might have Associate Professor Andrew Chang come back and help us answer some of those questions. Hi, so first question we have is, are there any particular autoimmune diseases that can increase the chance of geographic atrophy?
Very, very good question. Essentially, no, but there are a number of autoimmune disorders that can affect the retina. For instance, they can affect other parts of the eye, such as the retinal vessels in particular. They can affect the neural layers, but not the retinal pigment epithelium as such, because probably those conditions are vascular related and perhaps are not affecting the pigment layer in that capacity. The other important aspect to be aware of is that the eye is or parts of the eye are quite immune privileged. So as the eye was forming, it was done in isolation with the rest of the body. So although the autoimmune disorders can affect other parts, it tends not to affect the pigment epithelium. It's the way different layers developed when we were formed in the womb.
Right. We have another question here. Can you refer to early and intermediate AMD as dry AMD, or is dry only used to describe sort of the late stages?
Very good question as well. Early macular degeneration is when there are a few drusen, and so that still is a form of early dry macular degeneration. As the drusen become, and the drusen being protein material that's deposited under the retina, as it becomes larger and coalesces, then it becomes what we call intermediate. Intermediate really relates to the size of the drusen, the numbers of drusen and their location. And that is also then intermediate dry macular degeneration. And geographic atrophy, which then develops, is more advanced dry macular degeneration. So it's all dry.
Perfect. Thank you for that clarification. Yeah. Next question. So you talked about quite a few different types of clinical trials that are occurring or may occur in the future. How can we be involved in those clinical trials?
I think the first thing to do is to contact your eye care professional, optometrist, your ophthalmologist. So many of you may not be under the care specifically of a retinal specialist, but an ophthalmologist will look after you and is able to answer this and care for you. it's worthwhile asking whether or not your form of macular degeneration may be suitable for a trial. And if so, then you may be referred then to a site to be screened for this, for a suitable trial. Once you're screened, the criteria, for instance, the photos, the level of vision, the imaging and that is done, is sent to a reading centre, and they then will determine whether a patient might be eligible. So for clinical trials, there's this concept of inclusion criteria, and that is the type of patient that trial is actually targeting in order to study their drug. But I would reach out to your eye care professional, probably more than so much your GP, but you could also ask your GP, as they may also be working with an eye care professional to refer to ask if there are any new treatments, any new trials that are on the horizon. So increasingly, I must say that personally, almost every week there are at least 2 studies that are reaching out to us looking to recruit. A lot of the sponsors or the drug companies are based in the US or in Europe, but they are very impressed with how Australians, both as investigators and Australians as subjects in trials, perform. That is, we do them well, we do them diligently, and so they're reaching out to us down under now, wishing us to contribute.
So plenty of opportunities for people to join.
Plenty of opportunities, yeah, correct.
Perfect. Another one, can Apellis and similar drugs be used in the intermediate stage, or can it only be used in the late stage?
Well, that's a good question as well. When drugs are being tested, they have to limit themselves to a certain condition. And so in these trials, we're looking at geographic atrophy, or once the shag pile carpet has worn thin and we've got a bald patch. But if that works, then you might then go earlier and say, well, could I, if I was going to do this in eyes that haven't got a bald patch yet, but are thinned out, so I could prevent the bald patch from happening, that would be the question. And often a trial does that. It may aim for one particular focus, and then in the next study, they may expand their indications.
Right, perfect. Moving on to the next one, is the increase in risk of wet AMD outweighed by the benefit of slowing down the progression of dry AMD?
Right. I'm not sure what that question's aimed at, but I presume it's in the context that a patient has wet macular degeneration, is undergoing treatment for wet macular degeneration, has a little bit of dry as well, and there is a thought, still unclear, that treatment with injections for wet macular degeneration, particularly high frequency, might push the dry macular degeneration a little bit more quickly. One study found that was the case. However, it really is quite uncertain, and we have done studies as well, published, which I think I showed on my slide, which show that there is no relationship. So the short answer is, if a patient has wet macular degeneration, we need to treat this aggressively to maintain sight. That is to keep the retina compact and dry. The dry macular degeneration will continue to develop in parallel. So I can imagine if we go into the future, we might be giving a combination treatment. Somebody might be having a treatment where we are cleaning the shag pile carpet from all the muck and mud, and that's the wet. But we'll also be able to address the dry in concert. together as well.
Yeah.
So if you are having treatment for wet macular degeneration, it's very, very important that we continue to treat that. And currently that is a very effective treatment. But you might, an individual patient may be aware that even though they're having a lot of treatment to keep the dry component under control, their vision might be slowly worsening, and that's because of the wet. Sorry, that's because of the dry.
The underlying.
Is that clear? Yeah.
Yeah, definitely. Okay, next question. Do positive lifestyle changes actually slow the progression of geographic atrophy, or do they mostly slow the progression to wet AMD? It seems like underlying disease mechanisms are the primary drivers of progression.
Very good question again. So these lifestyle changes don't simply relate to macular degeneration. It relates to everything. We are machines, so it affects every part of our body. So our proper diet, regular exercise, regular checkups, keeping other comorbidities such as your blood pressure under control, keeping cholesterol under control, not smoking, right? That has benefits not only in the eye, but elsewhere in the body, reducing alcohol consumption. So the answer is yes, and very much yes, and not only wet and dry, but in a much wider systemic and perspective.
Perfect. Now, this next question, I'm not really sure what they're trying to ask, but maybe you'll be able to answer it. The question is, what is the side effect profile of Zimura? Is the wet AMD incidence / increase similar to ALP2?
Yeah, now that's a very good question. In all of the studies that have been done, we also look at other adverse events. One of the trials which the question referred to, actually in that trial showed it was a slightly higher incidence of wet macular degeneration. Now, it's uncertain as to whether the drug itself has caused that, or it's in the cohort of patients they happen to choose, or whether it's unrelated to the drug. I'm not aware currently of these issues with Zimura. In fact, I've got my head of research just on my right-hand side checking it up now, and we'll let you know if it is, but I don't believe so.
Right. Okay.
That's a very insightful question. Yeah. Okay. Yeah. Only APL2, not Zimura at the moment. There's no data for that. Yeah.
Right. Perfect. So I think given the time, we'll come to the end of our questions. Thank you so much for that, Associate Professor Andrew Chang. That was extremely informative, as I said before, and thank you so much for answering everybody's questions as well. And we're honoured to have had you today. Thank you.
Thank you, Delaney. Thank you very much.
So much.
Bye-bye.
Bye.